Audio, green. We don't like
Good
this.
morning, everyone. Good afternoon. Sorry. I'm forgetting what it's been a long day. I'm Kim Meerman. I am the chair for this subcommittee, which is part of the Autism Spectrum Council. And I really appreciate people being able to make the time to come here today. We do have a very packed agenda. So if Tara, if you can pull up the agenda, I can help everyone. Thank you. So today we have the opportunity to hear from two other councils that will be able to fill us in with their work and what they've been doing. So we're going to spend some time hearing from them. And then I'd like to have a discussion about our priorities for this year and what we want to be able to move forward with. And we will close with a proposal, policy proposal that came from one of our members and talk that through. So on that note, I would like to welcome Walter Glum. Walter, are you here?
I am here. Hello.
Walter, thank you. And thank you for taking the time to come and talk to us. We are trying to do a better job this year, being really organized with our legislative priorities and our actions around that. And you have such a wonderful work that you've been doing with the Disability Council. So we would really like to hear from you and the work that you've been doing and some of your latest priorities.
Well, thank you. If you'd like to hear all of that, I encourage you to come to our annual meeting tomorrow at the Chrysalis Center in Hartford, because we do a lot. I mean, we've got a pretty broad spectrum of activities, and it takes hours to get through it. So today I'm prepared to just introduce you to our policy priorities, and particularly issues that we think bear on autism. And then we go from there. There's a lot of other things we do. Before I go any further, I want to introduce one of our council members. Kathy Strout is on the call with me today. Kathy is our vice chair, and she is a mom who has an adult son on the spectrum. Kathy, say hello.
Hi, everybody. Hello. Yeah.
Do I have screen sharing enabled?
I can do that. Hang on one second.
Yeah, because I have, this won't be, we're not going to overdo it here, but I do have a one page of like bullet notes that I'd like to work from, just so I don't forget anything.
All right, see if you can now, Walt.
There we go. Let me find it, and there it is. Do you see my notes?
Yes.
Okay. Thank you. Well, so let me, first of all, for those of you who aren't familiar with the council, we are the Connecticut Council on Developmental Disabilities. We're an agency or a department of state government that is entirely funded by a federal pass-through grant from the, it's the Federal Department of Health and Human Services. I'm not sure which office we're attached to nowadays because they've done some reorganizing under the new administration. Our job is to work on policy and long-term issues. We work on a 5-year horizon of policy issues that support home and community-based services for people with developmental disabilities. And our definition of developmental disabilities is a bit broader than they have in Connecticut. I won't go into the details here, but it does arguably include autism along with a number of other behavioral and intellectual, cognitive, as well as physical impairments. So having said that, again, if you want to learn more about the council, feel free to follow up with me. Or if you're in the neighborhood, stop by the Chrysalis Center tomorrow in Hartford, as we'll be doing our annual meeting in person for the first time in 6 years. What I have here are just a few notes on what our priorities are. And the top part here is our policy priorities that drive our legislative advocacy to the extent that we see places where the legislature can do something about this. But we also engage the administration, the cabinet, and and a today or of private providers on these things. So let me talk about those first. Easily our number one priority is housing. It is the linchpin. I mean, you can't have home and community-based services without a home, right? And the model nowadays that we support and that I think is going to be the most effective and fiscally feasible going forward is a supported living model where people rent, well, I mean, they can own, but more likely rent, housing, and then receive home community-based services there. The problem today, of course, is it's all over the news. We don't have enough affordable housing stock in Connecticut. So, we'd like something needs to be done about that in terms of, legislation or policy. 5,000, House Bill 5002 is a big disappointment this year. I won't dwell on that, because I think you're all aware this has been a very tough nut. But I just want to point out that our emphasis is there. It's on generic affordable housing, rental assistance, and then the home and community-based services that go with that. We generally do not support segregated, congregate, specialized settings for people. The idea is to have the services and supports attached to the person so they can live where they wish in the community. Our next priority is access to healthcare. We did some work during the pandemic. We ran a clinic supporting people with developmental disabilities. And we learned that a lot of folks, not only were they not getting their vaccines because the accommodations weren't available at vaccination centers, but they weren't getting their general health care, especially primary care, because accommodations weren't available at the clinic or at their PCP. So we've got a project, so we're looking for support there to basically enforcement, as far as the legislature and the government goes, enforcement of the ADA requirements on the healthcare industry, that people with disabilities be accommodated in any setting. Our next issue, which perhaps you've heard of, is our concern about eligibility for home community-based services. Connecticut is almost somewhat unique nationally, certainly an outlier, in that we have a large number. We have 10 distinct HCBS waivers under 1915C, a section of the Medicaid. That's a lot, and they all have their own eligibility criteria, and they're all relatively narrow compared to other states. And the result of that is that a lot of people fall between the cracks. We have people who have the same kind of needs as my son, who's easily eligible for DDS because his IQ is under 69, but they're not eligible because their IQ is too high. They don't have a diagnosis of autism. They don't have a mental health diagnosis or whatever. And we want to see that fixed. Other states don't do this. Other states have broader functional eligibility criteria. So that's something we continue to work on. Of course, we have a long history advocating for competitive integrated employment. In order to get there for people with high levels of need, we need more support for things like customized employment. And although some of these things exist on the books, they're not well staffed or supported either at BRS or at DDS. So we're looking for improvements there. One of the reasons some of these things aren't happening is that we've got a workforce shortage. We don't have the people in place to do the work that needs to be done. So, we need to, a lot more needs to be done on workforce development. And it's not as simple as the wage issue. We've done a lot to increase wages for workers in these categories over the past 6-7 years. But what we see is specifically a lack of workers to address high levels of need in any of these systems. I mean, even at DDS, with people who are eligible and receive funding, we don't have the capacity at the providers or in the self-directed system. We don't have enough people with the skills who are willing and able to work with people to high levels of need. The other place where we're lacking is in the employment space. We don't have enough workers trained in job development, in customized employment. We have lots of workers out there, sitting with workers in relatively low-level jobs, basically as attendants. but we don't have enough workers who are trained in customized employment skills, job development skills, working with employers on how to create opportunities for people. And then there's a whole transition thing. There's still a bit of a cliff there. Despite, decades of work in this area. And part of the issue appears to be just not enough quality information going to families in those transition years. My son's 37 now, so I went through this some time ago, but we're surprised to find people in special education now who don't know, for example, that their child is entitled to special education until age 22. And, their districts are handing them a diploma at age 18 without discussion, things like that. Never mind giving people, proper orientation to the adult service system and setting realistic expectations about what you're going to get. There are waiting lists. There are, as I said, there are these cracks between eligibility silos. So we need better work there. And I added an emerging concern of ours that this is new this year, a general concern about basic civil rights as the federal government, has made it pretty clear that they're not interested in working in that area any longer. Department of Justice has published several memos making it clear they're not going to be prioritizing civil rights cases. They're going to be going after immigration issues and other things. And what this means for us is I think the state of Connecticut's got to step up. Fortunately, our state constitution and our state statutes are pretty strong when it comes to civil rights of people with disabilities. And I think we need to turn now to state law and the state constitution instead of the U.S. Department of Justice or the U.S. Department of Education or HHS. So that means getting the CHRO, the Commission on Human Rights and Opportunities, involved, getting the Attorney General involved, the Department of Public Health, but state offices, state law. And we actually had a press conference on this a couple of months ago. I don't know if you saw it. Be happy to send you the link. So those are our, as far as our legislative agenda, so to speak, those are our priorities. Okay, the second part of the page here goes into what I would consider the issues that we're pursuing where, there's, I think, a clear nexus with autism. And again, we work on a lot of different things, and arguably anything we do is relevant to people with autism. But, of course, at the top is the eligibility issue. Okay. Is the autism waiver sufficient? Does it offer all of the services and supports that anybody would need? That's a challenge because, the spectrum is broad and there's a lot of different things there. I think it's my opinion, and you can challenge me on this, and I'd be happy to admit that I'm wrong, but it appears to me that the waiver was created with a presumption that people with high levels of need all had an IQ of 69 or lower, so that somehow they'd be taken care of by DDS. And that's not the case. Level of need does not correlate well with IQ at all. So you do have people with IQ over 69 who have needs that might be met with the type of services that DDS has, but they're not accessible. Now, I'm not sure that the answer is DDS. I've been having these discussions with the commissioner. Some think that the answer is the 1915K, what otherwise known as Community First Choice. But Medicaid's got some funding problems, and the state's been clamping down on that. So, what is the answer there? And it's really not just about autism, right? There's folks out there who don't have, intellectual disability or autism. They may not have any label, but they still have needs. And what are we going to do about them? But even within the autism community, where are the services, and are they all accessible or available? An issue that's been raised because we have a member of the council, not present, but have a member of the council who's an adult woman on the spectrum, who's flooded me with documentation on this. apparently there's a real thing about diagnosis, or lack or failure to diagnose autism in adult women, and then having adults proper services for them. I don't know where we go with that. Okay, but it's an issue that's been brought to my attention, and I feel that I need to reflect it here. Then, of course, affordable supported housing. I already touched on that on our other list. But everybody's got to live somewhere, and we don't have enough affordable housing in Connecticut. And people with developmental disabilities, including, I presume, many people on the autism spectrum, don't have high incomes. So, you know, where are they going to live? You know, how are they going to afford to rent or whatever? Then there's the employment issue. You know, there are individuals with autism who can perform quite well, in fact, exemplary job in some positions, but getting into the system may be a challenge for them. You know, the interview system, the application system, do we have the right accommodations there for those individuals? And how do we facilitate that? And then, you know, once they're on the job, you know, what accommodations might they need? I mean, these are things they have in common with folks with intellectual disabilities, although the natures of the accommodations may be different. And then the question always comes up for any of these groups is there some incentive that we should be providing to industry? Aside from the fact that we won't sue you because you're violating the ADA, but you know, there. So employment, mental health services. This is one, you know, for people, more and more we're hearing from individuals who are adults who are on the spectrum and the nature of their needs, you know, it's behavioral, right? You know, and it looks like it might be something that would ought to be served in the mental health sphere. But more and more we hear of people being categorically denied access to DEMIS because they have an autism diagnosis. I don't understand that. I need to, and I'll admit, I need to understand DEMIS a lot better than I do. Because, you know, if we're going to live in this siloed arrangement that we have in Connecticut with, you know, separate cabinet level positions for mental health and intellectual disabilities and, you know, vocational rehab and so forth and so on, you know, where is that line, you know, between DEMIS mental health services and autism as we're defining it for on the autism waiver, right? Is that understood? And couldn't the DEMIS system be doing more? And you know, that means understanding that system. Now that system is largely, it's not waiver funded. It tends to be more clinical, which means there's Medicaid money there, but it's all, you know, it's medical. You get diagnosed with something and it's all treatment oriented. So it's a medical model, which is not necessarily what we're looking for, okay? Which brings me to my next point, was on the community first choice thing. IADLs, right? I mean, what a lot of these folks need is support with IADLs. Connecticut, when Connecticut wrote its K amendment, its K option, which let's be clear, that's not a waiver, that's Medicaid state plan services. So it's an entitlement, like any part of Medicaid. But they wrote it a highly restrictive version. Again, other states aren't like us. States like Colorado, for example, has a much more expansive K option. They still call it community first choice, but I don't think you'd recognize it compared to what we have here. What we have here is extremely narrow, and that seems to be our thing, right? We have narrow eligibility for DDS, we have narrow eligibility for community first choice, and so forth and so on. Again, it's just you're creating big gaps where people are going to fall through. There's a legal question about whether it's even allowable for Connecticut to exclude IADLs, and Sheldon Tubman's handling that, and we'll see where that falls. But you know, where are the supports for those? Now, the DDS system, of course, you know, naturally provides a lot of that kind of support, but it's not available to people with IQ over 69. So, you know, what's the answer? Do we expand DDS? or do we build those services somewhere else? And why not? Why can't we do that under the K amendment and so forth? So I think we're struggling with what's the most practical way forward at the end of the day in the current environment, working off of the system that we have here in Connecticut now, which is not exemplary compared to some other other states. Okay, and then I added transportation on here because that's key. There's that there's the triangle of housing, employment, transportation, right? How you you need all three, for life to work, right? Do you have to live, next to the place where you're working? Well, that's not practical in Connecticut, right? And our current ADA footprint is very limited. There's lots of potential housing and employment that lands outside of our ADA footprint. So what are we going to do about that? What's the option for affordable on-demand transportation outside of the ADA footprint? Not that ADA is wonderful, by the way, right? If anyone who depends on that system knows that it ain't, that's not the answer. So is it microtransit? Is it something like the Freedom Ride program, subsidies to existing providers, or what? Or is it changing the paratransit fleet and expanding it? I'm again getting back to DDS. I suspect that the DDS provider system owns more vans than we have in our entire paratransit inventory. And those vans sit unused for hours during the day. So where are the assets and how do we bring them to bear on this to make it all work for people? So there it is. I mean, I hope I didn't take too much time, but this is intended to be a top level introduction of what are the policy priorities, or what you can say legislative agenda, and it's housing, healthcare, eligibility, employment, workforce transition, and then those some of those things on the bottom there where there's already some overlap. Happy to take any questions, and I will stop sharing.
Thank you, Walter, so much. What questions do people have for Walter? Or any commentary for Walter?
Walter, that was wonderful. What
It
a
was.
great presentation. You hit on such important points.
To all of us.
Well, thank you. I mean, we all know that although stating the problem is an important step, it's just the first step. And now what, right?
Yep.
And that that would get me into the whole rest of our program, where we are, or most of our money that we get from the federal government, we put in grants to third parties that work on various aspects of this, not necessarily, in directly focused on legislation, but to demonstrate or to evaluate, how we might resolve some of these things. But thank you.
And Walter, I think that's critical because many of the things that you have on your list are topic areas that we've been discussing. And, what's really running through my mind is how do we work together so that we can present, really a unified message, because there is nothing that you said today that wouldn't be applicable to some of the needs and concerns we have. And I would be curious to kind of get a little more open discussion, of course, but how can we do a better job collaborating and working together?
Well, collaboration is emerging as one of our premier activities, but even strengths. Some of you know that for more than 3 years now, we've been facilitating a community of practice to bridge aging and disability service networks. That's going extremely well, and we're getting national attention for that. And it's pure, it's collaborative, it's pure on the ground level collaboration between people, nothing formal. I'm beginning to believe that, formalizing these things is a kiss of death. What you really need to do is create safe forums, environments where the right people can get together and get to know one another and share a lot of information. Anytime I run an event where I bring people in from different silos, different departments, different sectors at the same table, I'm always amazed. Well, maybe not anymore, but for a time I was amazed at how little people knew about one another. And these are, I'm talking like, director level, bureau chief, deputy commissioner, people who've been around a while, you would expect would know a few things, and they do. I mean, they know about the existence of the structure and all these other things, but that's not the same as having a better understanding of those people and the issues they're seeing every day. And we're going to be doing more of that going forward. Acting as a convener to bring people together, because I agree with you. I think the way you address these things, housing is a good example, right? There is, as you can see it, in the news, a large, active, affordable housing advocacy network in Connecticut. But it really doesn't have a lot of faces of people with disabilities in it, right? There's mental health has a big presence there. It's a lot of it, of course, is an income issue, demographics. Unfortunately, there are racial and ethnic themes in there, discrimination. But how many of the legislators who are working on this, or the governor who vetoed the bill, see that as a disability issue? Okay, so, more and more, I think it's not just us getting together, but us being in the camp with the people who are working on transportation generally, right? I mean, we all know that when you do things for our population, you end up creating stuff that benefits everybody, right? But we need to get there, and it's not always easy to get a seat at those tables. I mean, everyone, there's not a person on the state who will say, well, I won't work with people with disabilities. But if you look at the behavior, well, there's something else going on. So yes, I agree. We need to do a lot more in collaborating. And I think in terms of the how, I think it's more of this. Okay. And either, we attend your meetings, you can attend our meetings. We're both public bodies. We're open to these are all public, FOIA areas for us, or we can, program time, just to have a few key people get together and share thoughts. I mean, there's, a whole bunch of people on this screen that I've been shoulder to shoulder with for, I don't know, 15, 20 years. So, sure.
Thank you, Walter. Anything else for Walter? All right. Tara, we now have from the Rare Disease Council, Leslie and Mary. Is that accurate? Do we have them here? I'm not.
Yes, they are
Okay.
on.
Okay, perfect.
Go ahead,
Les-
Liz. They're sitting together.
Yeah,
Oh my
So they're
gosh.
sharing a
Yeah.
screen.
Thank you. I now see you.
I'm
Welcome.
Leslie Bennett. I'm the co-chair of the Rare Disease Advisory Council and the representative for all rare diseases. My daughter Kelly was born with a rare metabolic disorder that was never fully diagnosed. She lived for over 30 years and was on a DDS waiver. So I'm very familiar with the waiver system and the problems it has and how it's changed over the years from the Department of Mental Retardation to the Department of Developmental Services. And I've seen lots of changes over the years with that. With me?
So, hi, I'm Mary Caruso. I'm a member of the RDAC. I have 2 adult children that were diagnosed early on with a rare progressive neurologic disorder called Friedreich's ataxia. So everything Walter spoke about, and I agree, it applies to so many different groups. It really would be beneficial if we all started working together. So yeah, that's all about me.
Yeah, Mary is the chair of our advocacy committee, subcommittee. If you don't mind, so many people don't understand rare diseases or know that much. We just want to give you a few facts about them so you can at least understand where we're coming from. Under the federal Orphan Drug Disease Act of 1983, and again, it was reaffirmed in 2002, a rare disease is defined as a medical condition affecting less than 200,000 individuals in the United States. In Europe, the definition changes. It's 1 in 2,000, and in countries all around the world, they have their own definition. So there is no standard set definition of a rare disease. According to NIH, there's more than 10,000 rare diseases that have been identified, and they affect more than 30 million Americans. They estimate it's 8 to 10% of the US population. NIH also reports that 75 to 80% of the rare diseases that they have identified are due to genetic variations. The remaining 20 to 25% are due to infectious diseases, toxicities, environmental factors, and acquired conditions such as autoimmune diseases. In the US, more than 60% of those living with a rare disease are children. The Europeans have data now because they have single payer systems that indicate that it's as high as 75% because these are genetic disorders that are present at birth. In the US, the top 25 pediatric hospitals report that rare diseases are a major driver of pediatric healthcare costs. About 40% of all healthcare costs are on patients with rare disorders, with the exception of asthma, ADHD, autism, and obesity. All of the other chronic conditions of childhood are considered rare diseases, and this includes pediatric cancers. Very few physicians are trained to recognize or treat rare diseases, and there's very little reliable information or public resources for rare diseases. So there's a lack of awareness around the United States about them. Some patients wait years for an accurate diagnosis because our conditions are very complex and they often present with symptoms that are similar to more common diseases. This leads us to a diagnostic journey, which involves misdiagnosis or delayed diagnosis. And the GHO estimates that for us, with these delayed diagnoses, the costs are over $500,000 per individual. Less than 10% of rare diseases have a single FDA-approved medication, and these medications are extremely expensive. So we get a lot of pushback from insurers and Medicaid departments about covering them. This is one of the problems that we have. Rare diseases are often chronic, lifelong medical conditions that can be debilitating, life-limiting, life-threatening, and progressive or degenerative, and they often require long-term care. In Mary's case and in my daughter's case, that is very true. PKU, some of the more common or more well-known rare diseases are things like PKU, Rett syndrome, cystic fibrosis, hemophilia, Tay-Sachs, SMARD in the United States, sickle cell anemia, Friedreich's ataxia, Angelman syndrome, and a whole slew of metabolic disorders. In Connecticut, there's approximately about 100 patient organizations to help support us. There's at least 50 companies that work on rare disease products in some way, shape, or form. We have 3 medical schools and 4 major academic centers that help us, along with Jackson Labs. NIH estimates that there are about 300,000 patients in our state living with rare disease, and that's more than the population of both Stanford and Bridgeport combined. So that's quite a large number. For 60 years, the Department of Public Health has been, even though DPH denies knowing much about rare diseases, they actually have been involved in rare disease testing for the last 60 years through the newborn screening program. Currently, they detect more than 75 rare diseases. And there are 2 companies here in Connecticut that are involved in whole genome testing, Alexion and GeneDx, that are pushing at having the addition of that testing, rapid whole genome sequencing, to our program to expand it to over 400. They think that would work a lot better in identifying children early. According to GHO, rare diseases place a huge emotional, physical, social, and financial burden on patients and their families, their caregivers, and our state. Rare diseases can be classified by etiologies such as genetic or inherited disorders, autoimmune disorders, infectious disorders, cancers or neoplasms, and environmental factors. They can also be classified by the body system or organs affected, such as neurologic and neuromuscular, cardiovascular, respiratory, endocrine, hematologic, skin or dermatologic, and skeletal or connective tissue disorders. So you can see that we have a wide variety. According to the European Union, NIH, and data from Orphanet, approximately 50% of all rare diseases have a neurologic component. So that's the biggest area. The European Union has data showing that up to 70% of all children with rare diseases present with neurological symptoms, often neurodevelopmental symptoms. Physicians at the Intellectual Developmental Disabilities Research Center at Kennedy Krieger Institute and Johns Hopkins University have told members of the RDAC that there are more than 2,000 rare disorders that are the known genetic cause of intellectual and developmental disabilities, and that there are probably about 1,000 rare diseases that are genetically associated with autism. So we have a definite overlap, and we really do want to work with you and the developmental disabilities community and all other agencies in the state. Any disabilities group, we have a huge connection with. Rare diseases that cause rare and genetic and chromosomal disorders causing intellectual disability include Fragile X, Williams syndrome, Prader-Willi, the only disorder that DDS technically recognizes by law, Angelman syndrome, Rett syndrome, Charge syndrome, Smith-Magenin syndrome, Noonan syndrome, Cornelia de Lange, tuberous sclerosis, neurofibromatosis, and all metabolic disorders lacking a treatment. It's not uncommon for autism and rare diseases to overlap, especially in rare genetic conditions that cause neurodevelopmental disorders. And some of the ones that we see are, again, and you've already heard them, are like Rett syndrome, which you guys recognize as part of under the ASD umbrella, Fragile X, Cornelia de Lange, Phelan McDermott, Angelman's, and all metabolic, neurodevelopmental, and neurodegenerative disorders affecting the brain that can cause autism-like symptoms. And so oftentimes we see these in disorders like Sanfilippo disease, MSP3, or mitochondrial disorders. So yes, there's a huge overlap here. Right now, the RDAC has not established its priorities, legislative priorities for 2026. A lot of the things that Walter mentioned, yes, those are issues for us as well. And we're waiting to hear from patients within the state and our community, not just patients, all of our rare disease community, at our next 3 public hearings on September 30th, October 26th, and December 9th. These will be 2-hour public hearings where we devote a half hour to our meeting, and then the rest of it is all where we hear from the public about what's important to them. And we learn quite a bit. This is where we really develop prioritize our issues for the next session. So you're all invited to that. You're all invited to join our advocacy committee and our awareness committees. They're open to the public, and we really encourage members to join us and work with us on this. So the 2025 issues that we weren't able to address, the 2 issues that were tabled in 2025 by the CGA that we would like to address this next session are emergency protocols for individuals with rare and special healthcare needs. This is essential to us, especially as we're watching emergency departments being outsourced. It's a huge issue because then even if your child or the patient is treated at a particular hospital, these outsourced emergency rooms are no longer able to access the records within the hospital. So it becomes a life-threatening issue for anybody with special healthcare needs. And it was tabled more because they didn't understand it. We also we're going to be arranging a meeting with EMS
Right.
services in the state to talk about this because they're not aware of
Yeah,
the
we
issue.
think collaboration and some education will really
Help
help
with
move
that.
this along.
And then the other thing that we're working on, I think a lot of you have probably seen the story about Chloe Negron, the Negron family in a lot of the papers. She was diagnosed with juvenile Tay-Sachs disease, and it has a lifespan of up to 3 years. She did not live for 3 years. And the family tried to get a Katie Beckett waiver and then even a DDS waiver. There's not enough time. The waiting lists are too long. And she died in less than 2 years. So what we're going to push for is years ago, I know when my daughter Kelly was very little, We got a conditional waiver through DDS. There's kind of a donut hole in that DDS program between the birth to 3 program and then when they test the child at age 7 for intellectual disability, it's like a donut hole and these kids fall through it. Technically on the books, there's still a conditional waiver for some of these kids who are diagnosed with, like my daughter was, severe or marked global developmental delays. These are the children who are never able to sit up, walk, and talk. So we would like to see that something like that reinstituted, or some sort of compassionate waiver for children, especially, we'll start with children, but especially children who are born or diagnosed with a rare disease that we know is fatal. The life expectancy is maybe 3 years, to help these families, because these children, their disorder goes very quickly. They decline extremely. These are progressive neurodegenerative disorders, and these families need help immediately. I know for me, when we got the waiver for Kelly, it was a godsend. Initially, it was only 20 hours a week, but it allowed me to sleep. It allowed me to go to functions with my son, little things like that. And then as she got worse, I mean, people complain about the fact that DDS comes in every 6 months. To me, it was a godsend, because as her condition got worse, they could come in and give us more hours in nursing. They could also recommend care coordination, things like that. So these are things that we need, and we plan to go in and talk to DDS about this. They're aware of that. But those are the 2 main issues that we're working on. Other things that we always do, our community is already talking to me. We need to ensure access to treatment, especially orphan drugs, timely diagnosis, safe quality medical care, and affordable insurance. One of our primary issues will also be expanding newborn screening with the disbanding of the committee in Washington that normally decides which tests will be added to the panel. There's 2 that we would like to see added: Duchenne muscular dystrophy. There was a bill in the state last year for it. And then MPS, MLD, metachromic leukodystrophy, is the other one we'd like to see added. Those 2 are ready to go. We'd also like to see, ideally, we'd like to see insurance coverage of rapid whole genome sequencing for critically ill children who lack a diagnosis. This would speed up things, and it would help save healthcare costs all around. I know it's a tough task in the state, but it's something that's worth addressing. We got it passed for Medicaid 2 years ago, and we'd like to see it expanded, to go on. We'd like to see insurance protections for people with rare diseases and special healthcare needs strengthened, like the off-label use of treatments for when medical evidence supports the use in rare diseases. Ensure that patients have access to orphan drugs, and that state agencies protect access to orphan drugs during any of these cost analysis reviews. The state does a top 10 most expensive list, and our drugs are so high in cost that they are a target for this. So we would like to see some protections there for that. We know that sometimes these drugs are also used for more common things. Well, we'll work with that, but we'd like to see protections there. We'd also like to see a cap on out-of-pocket costs for vital orphan drugs and specialty therapies for used to treat rare diseases and special healthcare needs. We'd like to see some Medicaid flexibility to ensure coverage of rare disease therapies, even when some of those therapies may have to be administered out of state. We'd like to expand access to state services and state waiver programs, just like everybody else in what Walter has talked about. We'd like to see expanded care coordination coverage, expanding telehealth for rare diseases to include genetic counseling, and education accommodations. We'd like to see that strengthened for rare patients with rare diseases and special healthcare needs, and IEP and 504 plans. So those are what we're kind of looking at. As far as advocacy, we need to, and one of the things I'd like to talk to all of you about is maybe getting some sort of panel together to educate the governor, CGA, and state agencies and health policy decision makers in the state about the needs, our combined needs, and the needs for waivers. All of us have those needs. And you're right, Walter. I mean, the DDS waivers were originally designed for it was the Department of Mental Retardation. So yes, that's their primary focus. But we should have a developmental disabilities waiver as well. I mean, there are people that are severely disabled and they may be fine intellectually, but they can't do anything else. And what are we going to do? Those families are struggling. So yeah, that's what we'd like to see, and it would be great if we could do that. We inform the governor and the CGA about the rare disease community. Every year we hold a rare disease day, and we would encourage you all to come and participate in it, where we talk to legislators about rare diseases, our needs, and what we can do. We testify at public hearings, and we meet constantly with CGA members and members of the state agencies. Agency training for us is huge. They don't understand us. Even DDS doesn't understand us. The Social Security Department has a list of rare diseases for which they give compassionate allowance. We'd like to see DDS be more aware of that, because these are disorders that really need help from them. And they're not even aware of the fact that a lot of our disorders are progressive. So a child might have an IQ of 70 today. 2 weeks from now, that IQ will be down in the 60s, and they won't retest. And it's just like, no, this is a problem. You need to be more aware of the disorder and what a progressive disorder means. So these are things that we need to work with. And so the agency training is huge. We would like to get into DDS, DSS, DPH, and OHS. OHS has no clue. They review these drugs, the most expensive drugs, but they have no clue of the Orphan Drug Disease Act, or where to even find out information on it. We went in and talked to them earlier this year, and they're going, well, where do we find out information? Check the FDA site. For the last 40 years, they've listed all drugs that have an orphan drug designation and when that designation expires, and if it's being used for more common disorders. These are things that they can check very quickly, but they didn't. So it was just a huge thing. We need to educate the public, and we'd like to work with all of you to do that. We do, through the Denise DeCenzo Foundation, we're now starting to get more access to media. So we'd like to start educating the public more. We hold public hearings and encourage all of you to have input in that. We'd like to participate in all healthcare meetings, including yours, and functions around the state. And we want to collaborate and work with all of you. So that's kind of where we're at.
That's it.
And Walter, you had a great list of all issues that affect all of us. So we are not going to touch on that today, but that's kind of where we're at. So any ideas you have for issues that we can address? I apologize for last year blowing apart your legislation for changing the DDS waiver process and definition, but I was asked by the intellectual disability community to speak about it, because Kelly had been on one of their waivers. And I was one of the people who knew that 15 years ago, it was about 15 years ago, the state went through and set it at 69 because of financial considerations. And that's what they focus on for all of these waivers. And it's one of the things we're going to have to address with the governor. I think if we could get together and have a meeting with key members of the CGA, the governor's office, and state agencies, maybe hold it up at the State House, sometime between now and the end of the year before the session starts. That might be a great step. And I think if we all work together, we could approach them about it.
Thank you. Very good suggestion. What questions do people have of Leslie and Mary, or comments? I personally agree that collaboration. Oh, we have a question. Yes, come forward.
Good afternoon. Hi, I'm Kathy Marchioni. I work for the Bureau of Rehab Services. Walter and I have, in fact, worked together plenty of times. It's good to see you. And I have to jump off to another meeting, but I just want to, this is not a meeting I'm usually able to attend. I am just so glad to have been here and hear all the information that all of you provided. It matched up very closely with our experience at BRS. So certainly, I think some of you have my contact information. For anyone who doesn't, please, you can get it from Tara. I'm a state employee. You can get it on the website. Please reach out. This was great information. Thank you.
Thank you. Other questions or comments? I thank you all for coming today, because I really would interested in the collaboration. I know that many voices can get us far, and we similarly have a lot of the same issues that you are both talking about today. And part of today's meeting is to kind of go forward and talk about what are our legislative priorities and where do we want to go as a group. And there is going to be a special session coming up. So that would be one of the first things that I want to approach is what would we want to be able to support for this session. Tara, can you flip to the next slide for me? Thank you. I appreciate that. One of the things that we tried to work on last year is that for those of you who are unaware, that ABA or Applied Behavior Analytics Services are only mandated through age 21 here in Connecticut. It is really the only service that has such an age cap. And, you know, as you know, I'll speak as a mother. My daughter is very reliant on that service, now 22. And we've been in a constant ongoing battle with our insurance company, thankfully, with the support of my husband's employer, where we have her insurance, because they're in agreement with us that, you know, such vital services should continue. We were very fortunate that a bill did go through the House, raising the age to 26, which I would still like to say that we need to advocate for lifetime, just like any other service. Unfortunately, that bill did not move forward to vote for Senate. So we're back sort of at ground zero here, trying to move forward in advocating for that bill. So one of the things that I'm hoping to talk about today is the ability to put forth a letter of communication and some advocacy towards raising that bill again, so that we can actually get this voted on and supported. It does appear to have bipartisan support. So we just need to get it through the process. So we would like to reach out to the legislators that had initially sponsored the bill. We can send a letter as a council. And also, I have drafted a template where individuals can also send letters, really stressing the urgency around this change. The other thing is that we could talk about requesting a time to meet with them and to really review our concerns more in a virtual session, but in person to be able to say, this is what we need and why. What questions or reactions do people have with this, pursuing this legislative priority? For those of you who are members of the council, are you okay with us moving forward with a letter?
Yes.
Yes, thank you. I appreciate that. I will work with Tara and Jimena to get a letter together. Tara, can you just go back to the other? Yes, thank you. The other one where we wanted to, one more. The original, yep. The original slide where we talked about our priorities. Is that, I just wanted to make sure. Okay. Nope, there was nothing else on there. I'm sorry, I thought there was information about the needs assessment. Would you mind, Tara, talking a little bit about the needs assessment before we move forward?
Sure, no problem. So we were able to, well, between DSS and OPM, secure grant funding for a statewide autism needs assessment. So I had sent that announcement out to the council members, so you should have received that. So that's going to be a 2-year process that we will, we're looking to replicate a survey that was done in Pennsylvania that informed waiver services in their state that has been replicated in multiple other states. So we were notified of the grant funding, but now we have to go through the state process of putting out an RFP and securing a vendor to do that work. So I don't have anything else at this time, but just the announcement that the funding has been secured, and that we will be moving forward with that. So we're hoping that this will be able to inform autism policy in the next, when we go into the next budget session, and hopefully the data will be ready at that time. And there will be a data dashboard that will have all of the results accessible on a website so that the general public and anyone can access that information. So
Thank
that's all
you,
I have
Tara.
now. To be
Thank you.
to be continued,
To
right?
be continued.
Yes.
But this will be a game changer for us when we're starting to talk about our priorities, because we'll have actual data behind our conversations, which I think is going to be critical. And in the last 4 minutes, Carol, so one of the things we've shifted to this year, and this is an open invitation for Leslie, Mary, and Walt as well with your groups. We have now on our website a policy suggestion form where anyone from the public can move forward and say, this is something that is of a need. So to make you aware that, and to invite you and your membership to participate in that at any time. And we do have one from Carol. So Carol, I'm going to invite you to come on and help support the presentation of your policy suggestion.
So one of the things that I think that would be interesting to look at is there's a lot of things that's interesting to look at, but the way the waiver is set up is that they are sort of in slots, and each slot is allocated $50,000 of services for that person. But I'm not going to speak for everybody in the state of Connecticut. I can speak for myself that of the individuals that I know, which is more than 25 individuals, that less than 10% use that $50,000. Less than 10%, I would say, use half of that $50,000. And that is not due, and that is through my company and other people that my company works with. And that's not due to us not having staff. So if those people wanted all of their hours, we might have a problem. But that is people turning the hours down. I have to have conversations with family members on a very, very regular basis, probably 5 or 6 times in the past year, 5 or 6 different families, to say, you need to accept one waiver service per month in order to stay on the waiver. That means 1 hour of BCBA, 1 hour of life skills, 1 hour of job coaching, just one. And we have people who are sitting on the waiver list, the wait list, or on the waiver program, who are taking up a slot, and they need a slot, and I'm not questioning that, but they are using 1 or 2 hours of services per month. And so I understand that we've talked about this on the, through the division in the past. And I understand that the rationale is to not change that is because if that person suddenly needs $50,000 and all of the hours, that that money would not be there. However, that has never happened in the 15 years that I've been involved with the waiver, and before that the pilot. So if we could have people with lower needs have a $25,000 cap, we could serve twice as many people. And I was gonna say, I think it was like, when I calculated the people that I work with, it was something like 6.9% utilize all or almost all of their hours. So I just wanted to possibly bring that up as something to revisit.
Thank you, Carol. And we have discussed this issue before. I see there's a question from Walt.
Hi, I just wanted to share that I've been a part of some similar conversations with the Medicaid director for the state of Connecticut about how they're going to bring down Medicaid costs over there at DSS, and they're looking at the DDS system, which, if you've seen it, it's everybody gets an individual budget, and it can be anything. I mean, it scales more or less with your level of need assessment, but exceptions are made all the time. I mean, it's quite a system. But the point is that, it's for a long time now, it's been variable per person, right? I mean, some people get larger budgets, some people get smaller budgets, depending upon their level of need and what that family requests, and what falls out in their discussions with their case manager and the region. And it's managed. I mean, the concern that somehow because you have a smaller budget, $20,000, $15,000 a year, that somehow you will not be able to get more later if you need it. I mean, it's not true. I mean, because DDS has been running that system for a couple decades now. And as I said, I believe DSS is looking at it for other parts of Medicaid now. So I don't understand. I've heard about this issue of the $50,000 block, per person. And I agree with you. It just doesn't make any sense. And there are counterexamples right here in Connecticut where they're making that work with call it a sliding scale, whatever you want to call it. But you're suggesting tiers. That's one way to manage it, but you don't even have to have tiers. You can have a continuum and still make it work. And as I said, there's a whole case management system and budgeting system at DDS that works that way right now. And it's working. I mean, I'm not saying it's perfect. I've got my issues with DDS, but there is a way to do it. So I'll leave that with you.
Thank you, Walter.
The other thing, Kim, I think that it would be, and maybe it's a subcommittee thing for us, but to look at how other states are handling this. I know Massachusetts, which is right across the border. I live in Massachusetts. We don't have any waiting list for autism services. There is no waiting list, and anybody who applies immediately is approved for services. And part of that is there is no cap, and you're not offered every single thing. You're offered what's appropriate for your case.
The level of need.
The
Yes.
level of need. And there's a level of expectation that the person participate in the services. So if we look just next door to Massachusetts, there is no waiting list, and I don't see that it's been a hardship. And there are a lot of people getting services. So I just think there's some other ways to maybe look at things.
Thank you, Carol, for that suggestion. And I actually think that's a great idea that we can gather some information from other states and just bring it forward to another discussion at another meeting. The other thing that I just want to end, because I'm recognizing our time right now, is absolutely please, Walter, Leslie, and Mary, let your membership and of course yourselves know that we are also open and we want to have people attend and collaborate with you as well. I'm looking forward to continuing our collaboration and supporting each other, especially as we're trying to formulate our legislative priorities for this year. Anyone else have anything for the good of the order?
I'll
All
just
right.
add
Good.
real quick that I will drop the link to our website. That is the best place to find information on our meetings. The agenda and links are all posted there.
Thank you. And thank you, everyone. Thank you, Leslie, Mary, and Walter. I really appreciate you coming and sharing with us today.
Thank you for
thank you for having us.
having us.
All right. Good afternoon, everyone.